Hey everyone, so in today's video what we're going to do is break down the segmental behavior or the segmental interactions between the scapula and the humerus during a very commonly used assessment procedure for the shoulder, and that's looking at the shoulder's ability to extend, internally rotate and flex at the elbow to allow the client to reach up and touch the opposing shoulder blade, the opposing scapula. Very important to allow for clients to tie up their bra, to scratch their back, to tuck their shirt in. These are all things that are important activities of daily living, and many times clients that have a limitation in internal rotation at the shoulder will demonstrate a limitation or a pain experience with this. So I do think it's helpful to try and break down the interactions between the thoracic spine, the scapula and the humerus during this assessment procedure. Now, if we look at the skeleton here, I think we can all appreciate that this scapula here is more internally rotated, where the glenoid cavity is facing more forward. Now, if I was to grab my other scapula here, if I was to bring that back towards the thoracic spine, hopefully you can appreciate that that glenoid cavity now is facing more laterally into the frontal plane. So it's more externally rotated. So in previous videos, we've discussed how, again, when that glenoid cavity faces more laterally, this would represent an external rotation. So it's turning outward away from the midline. So you have your right scapula turning right, that would be an outward rotation. If your right scapula is turning left, that would be a medial rotation because it's the right scapula. So a protraction would be representative of an internal rotation, because again, that protraction, I'll put this down here for a second, that protraction would be a combination of scapular abduction, a gliding laterally, but then an internal rotation. Scapular retraction would be a combination of scapular external rotation and scapular adduction, where it glides medially. Okay. Now, key thing to consider here within the context of this inferior Apley scratch test is how it's otherwise termed as well, is that we have to appreciate what does a research, what do they actually try and look for in the research? What are they actually looking for when they look at this test? They're generally looking for the scapula's ability to externally rotate and for the humerus to internally rotate relative to that scapula. That would demonstrate that we have the ability to internally rotate or have the availability of internal rotation. So let's say this is the external rotation of the scapula. I'll point it this way so it can hopefully be a bit more clear. I'm externally rotating the scapula, but when I internally rotate the humerus, that will of course require range of motion between the humerus and the scapula, because if we don't have that range of motion available at the humerus to internally rotate relative to the glenoid, what's going to happen is this. We're going to internally rotate, but then if we don't have that range, then the scapula is going to also internally rotate, almost to the point where it's lining up that glenoid cavity with the humeral head. And the dynamics between the glenoid cavity and the humeral head is extremely important to consider here as well. So to show you that again, let's say that this scapula is externally rotated. We have the humeral head facing the glenoid cavity. Let's say I want to internally rotate that. Let's say I'm stuck here. The only way I'm going to be able to go back further now as I extend is if so you see that humeral head trying to point back. Let's say I don't have that range. Now the scapula is going to internally rotate to line up that glenoid cavity with the humeral head. That's going to look something like this, where you're going to see a client try to extend back, internally rotate, and then you see the humerus or the scapula anteriorly tilt, but also protract where it internally rotates, and you see a client trying to reach up to touch the back of their opposing scapula like this. Okay. So when we don't have that availability of humeral internal rotation, that's when you're typically going to see that internal rotation of the scapula. Another key thing to consider here as well is that, again, there is an extension component here of the shoulder, or where the humerus, and again, consider when we spoke about shoulder flexion biomechanics as well in previous videos, where when we are extending, let's say for example, we're extending the shoulder from a flex position. So if I was to, and again, imagine just the upper limb as a single segment here. If I was to extend that shoulder, notice what direction that upper limb is moving or rotating in the sagittal plane. Again, if you were to imagine that upper limb as a spoke on a bicycle wheel, that will be rotating in a forward direction, whereas shoulder flexion would be the upper limb segments rotating in the sagittal plane because it's moving on a curved path, on an angular path. It's not a linear motion. It's rotating in a backwards direction, okay? It's important to consider that there because typically that will couple with a movement in the same direction oftentimes. But again, it also should have the ability to couple in opposing directions too, where they have the ability to dissociate, or from a variability standpoint, like we discussed in some previous videos, have the ability to demonstrate an anti-phase pattern. So oftentimes when we are extending the shoulder, because that's a forward rotation, that's typically going to couple in the same direction, or it can couple. It doesn't mean this is going to happen every single time. And this is what I think a lot of therapists get confused about, is going to couple with a forward rotation of the trunk or a flexion of the thoracic spine, which will also drag the scapula into an anterior tilt or rotation as well. These are just all forward rotations, whereas a flexion of the shoulder, because it's a posterior rotation, will typically couple with a posterior rotation of the spinal column, where the thoracic spine will extend, scapula will posteriorly tilt, okay, to move in the same direction. So if I'm trying to throw something, let's say I'm trying to actually serve in tennis, that requires a lot of shoulder extension. Typically you won't see someone just serve a tennis ball just using an upper limb dominant strategy, but you'll typically see the trunk flex as well. So everything's rotating in the same direction, okay? So if we don't have the ability to, again, you can think of this from more of a kind of a global standpoint between the limb and the midline. If we don't have the ability to extend the shoulder without the trunk also rotating forward, because both represent a forward rotation, then that's going to limit our variability overall, okay? Because they're now moving in the same directions. We do want the shoulder to have the ability to extend while keeping the trunk a little bit more rotated posteriorly relative to that forward rotation. So the trunk stays backwardly rotated as the shoulder is rotating forward. That represents movements in the sagittal plane from a rotational standpoint or an angular standpoint in opposing directions, okay? Because if you see something like this, if you're asking a client to extend their shoulder, which is more of a humeral dominant strategy anyway, and they don't have that ability to do that, what you're going to see is that's going to drag the scapula with it into a anterior tilt forward rotation, okay? Again, nothing wrong with that if I'm trying to generate high forces, but if every time I try to extend my shoulder and that scapula has to go along for the ride, it demonstrates that I don't have the ability to extend my shoulder. I don't have that range of motion available between the humerus and the scapula, okay? So that's why you'll typically see that if someone lacks range of motion here between the humerus and the scapula, as they try to extend, scapula will tilt forward, and then when they try to internally rotate and flex the elbow, then if they also don't have that internal rotation available, then you're going to see the scapula internally rotate. And that's when you see something like this, where they'll try and extend and they'll do something like that, okay? Because they don't have that range of motion availability, okay? Now, what makes this complex is that, again, what I see clinically an awful lot, I'll see variation in the thoracic spine behaviors of individuals that have this limitation. And they also, again, have a pain experience. So sometimes they're just struggling to move into a range of motion or to allow for passive load to be experienced through certain tissues because there's a pain experience with that. So they're going to avoid that, or they're going to be sensitive to it. And that can mean they are going to use or adopt other strategies. And so oftentimes you'll see if someone has a limitation in range of motion, they'll actually adopt this in-phase pattern where segments are moving in the same direction, okay? Now, that may be secondary to a limitation in range of motion, or it may be secondary to a sensitivity with muscular tissues lengthening. Because for me to be able to extend my shoulder relative to my scapula, that requires for more of a lengthening of muscular tissues. When segments move in the same direction, there is much less there's much less lengthening of muscular tissues, okay? One example of this is looking at the infraspinatus teres minor that attach onto the lateral portion of the humerus at the greater tuberosity. Okay, so you imagine this here. So we have scapula, or we have the infraspinatus teres minor attaching onto the scapular fossa. They'll attach onto the lateral border or lateral portion of the humerus. If I try to internally rotate my humerus, that's going to create a lengthening of the distal attachment of the infraspinatus and teres minor. But if I don't have the ability to get length into that muscular tissue, what's going to happen is the scapula is going to internally rotate. So it's actually going to drag the proximal attachment of that muscular tissue towards the humerus. So there's not going to be as much lengthening or length change at that at those muscular tissues. That's why in previous videos, when we spoke about the importance of externally rotating the scapula as we drove into horizontal abduction, we're trying to keep the humerus internally rotated in the sagittal plane, keeping the scapula externally rotated, so that when we load, we're getting load into these posterior tissues here. But if we allow the scapula to also internally rotate, then we're not really challenging those muscular tissues as they're biasing length through them. Okay, so extremely important to consider that there. And so when I have clients, like I mentioned before, many times I'll see clients, again, that just have a limitation in humeral internal rotation. We may just simply have to address that limitation in range of motion. But if oftentimes you'll have clients that will be very flexed at the thoracic spine, and they may actually have a limitation in shoulder flexion. Now that limitation in shoulder flexion may be for a number of reasons, but of course we know that in order to get to the end range of shoulder flexion, we need the thoracic spine to have the ability to extend, which is a posterior rotation, to allow for the scapula to posteriorly tilt, to afford space and to facilitate really the motion of the humerus further into that posterior rotation. Okay, so that's extremely important to understand there, because in order for that to occur, to get to end range shoulder flexion, we have to have the thoracic spine to move into that posterior rotation, scapula to also be able to move into that posterior tilt and posterior rotation. So if we're trying to extend the shoulder, that may mean that as we begin to extend and internally rotate, my thoracic spine and scapula is already forwardly rotated, okay? And that's going to limit the actual independent motion of the humerus to actually move through a range to bring it into internal rotation, to extend and to reach the fingers up to touch the opposing scapula. So I want you to kind of do this little movement experiment for me. I want you to bring your, let's say your right upper limb or any upper limb in front of you, and I want you to bend your elbow at 90 degrees. In this position, you're actually in internal rotation. This would be more external rotation, this would be internal rotation, okay, where the triceps are facing laterally. And what I want you to do here, I want you to reach your elbow forward to protract and internally rotate your scapula. Keep that position there and try to internally rotate your humerus even further. You're going to find that you don't have a huge amount of range of motion here. But if you brought your humerus into the frontal plane now, and you allow for that, and try and keep the humerus in the same position. So now you have your scapula in more of an externally rotated position, and now try to internally rotate more. You'll find that you have more range of motion, because what you've done there now is you've brought the scapula back into external rotation, and you've afforded the humerus more space to internally rotate through. Okay, so picture this for me. With your arm by your side, if you were to try to internally rotate your humerus, you're going to get through a certain range of motion here. And once you reach that end range of motion, then your scapula is going to begin to internally rotate. Okay, but when you internally rotate your scapula, that's typically, for example, if you were to just protract and internally rotate your scapula, that's typically going to drag your humerus into internal rotation with it. Okay, so now you don't really have a lot more space to actually internally rotate your humerus through. So if you were to, for example, keep your chest nice and tall, arm by your side, internally rotate your humerus, you'll get to a certain point, and in order to go further, your scapula is going to internally rotate with that. That's a movement of those segments in the same direction. They're coupling in the same direction, okay? But that's going to then be important to consider when we're trying to allow for relative motion between segments. Because if you already have a situation where your scapula is internally rotated, your humerus is internally rotated, you don't have a lot more space to actually move through humeral internal rotation. So the key thing there that you need to allow for is you need to allow for that scapula to begin to externally rotate. Okay, that will typically, for example, if you were in this position here and you were to externally rotate, that's not necessarily going to externally rotate your scap or your humerus with that. Again, typically when we're in this position, naturally the upper limbs will be more internally rotated via the humerus. If you were to just internally rotate your scapula, that's going to typically drag it further into more internal rotation. So we don't have as much isolated humeral internal rotation to move through. The reason why this is important within the context of this reaching behind the back is that if I'm already in this position here, I don't have the ability to move the shoulder through extension via the humerus, and I don't have that much space to be able to internally rotate the humerus through. That's why you'll typically see everything kind of tip out to the side to get through that range of motion. So if you have an individual, for example, and this is just one of many situations you may see, if you have an individual who's already very flexed at the thoracic spine, and they're very, again, typically when the thoracic spine flexes, that's going to drag the scapula along with it into a forward tilt, forward rotation, and some protraction and internal rotation. So what we need to do in that situation, I find clinically, is that I need to improve their ability to extend the thoracic spine and get that scapula to move into some external rotation and posterior tilt. Where do we enable that to occur? In end-range shoulder flexion. So it seems paradoxical here, but I find clinically in many of these clients that I can get a good result in internal rotation and extension at the shoulder with elbow flexion to reach behind them if I actually make sure they have the availability of shoulder flexion first, okay? Because that will give the scapula the ability to, again, obviously it's going to upwardly rotate, posterior tilt, but it's going to also enable you to be able to get into this position, this extended position at the thoracic spine and this external rotation of the humerus, and afford the humerus, as long as that has the ability to internally rotate, okay? But here's the thing. If you have an individual who is very flexed at the thoracic spine, very protracted at the scapula, and you identify a limitation in humeral internal rotation, and then you try to specifically improve that humeral internal rotation, let's say with like a sleeper stretch scenario with more manual strategies, I found that doesn't really have very positive outcomes, because you're just driving them further into more of a in-phase pattern where the segments are moving in the same direction. You're actually not affording the humerus the ability to move independent of the scapula, because that scapula is already internally rotated. So what I found clinically is that if you work on improving shoulder flexion, which will naturally couple with thoracic extension and scapular posterior tilt and external rotation, and then, or simultaneously, you work on improving that local humeral internal rotation, you can get much better outcomes with clients with regaining that shoulder extension and internal rotation, okay? Because again, clinically, this can be quite a challenging motion to get back, but very often you're going to have clients that have limitations in shoulder flexion with that, coupled with that limitation in shoulder extension and internal rotation as well, okay? So in that scenario, I would try again to have a conversation with the clients. Maybe it's a situation where the client notices their symptoms much more frequently with this motion here. Let's say it's someone trying to kind of tuck their shirt into their jeans or their pants, or it's someone that's trying to tie up their bra, and they're very, very aware of that limitation there. We have to have a conversation with that client and, you know, try to work with their expectations there and help them understand that we need to improve that shoulder flexion initially and simultaneously improve that shoulder internal rotation if there is a deficit there, instead of just driving them further into that extension and internal rotation, because that's very seldomly the reason as to why they have a pain experience there. because they've been doing that for a long period of time, and all of a sudden now it's limited and painful. Why is that the case? Did we just force them further into that? Did we just try and drive them into that range of motion, and trying to manipulate or try to do that in a more tolerable manner? Is that really helping us restore that variability? So I think it just necessitates us to take a closer look at the variability across the thoracic spine, across the scapula, and across the humerus. And of course, it is complex, but to put it in very simple terms, make sure the individual has the ability to flex their shoulder first, and then either simultaneously or afterwards, then work on that more local humeral internal rotation range of motion, okay? And I found that has much more positive outcomes in terms of allowing clients to tolerate that motion and those rehabilitation strategies during clinic as well. And a lot of this as well, coming back to some previous videos that we went through, trying to get that local load into your posterior delt, your infraspinatus, your teres minor, looking at loading the posterior cuff at length. So take a look at those videos as well, because that will also allow for the scapula to externally rotate, for us to get length and load into the infraspinatus. Because remember, what also has to be able to lengthen during that motion there, the infraspinatus, teres minor. So if you don't have that ability to internally rotate, because the infraspinatus, teres minor, let's say for example, these tissues just have a lot of muscle guarding within them, and they're not tolerating that stretch very well. And so you're experiencing pain with that. You're going to see the client try to internally rotate, extend, and then the scapula is going to come along for the ride with that, because they're trying to bring that proximal attachment to the distal attachment at the greater tuberosity. And so trying to get some length and load, or try to identify strategies that give us the ability to get some length and load into those muscular tissues. The infraspinatus, the teres minor can also be very, very helpful as well. But hopefully you can appreciate here that it's not just about understanding this range of motion, this assessment procedure, but it's also about considering the behavior of the humerus and the scapula within the context of other segmental behaviors as well, and other subjective and objective limitations that the client will have. But hopefully this gives you a greater appreciation as to how the humeral head and the glenoid cavity will interact with each other during that motion, why you might see that thoracic flexion, why you might see that anterior tilt and internal rotation of the scapula when individuals are struggling to demonstrate that range of motion. There can be a range of motion limitation, there can be a muscular sensitivity there as well. It can be secondary to the thoracic spine not having variability in it, so as a result you don't have variability at the scapula. So again, I think this allows us to be a little bit more, or have more options to address these limitations clinically, instead of just thinking we just need to drive that humerus into internal rotation or drive the individual into shoulder extension. Okay, so allows us to take a step back and appreciate the variability between multiple segments. Okay, so like always, hopefully that was helpful. If you have any questions, please let us know below.